So thank you very much, Jill, for your very nice presentation introduction. Thank you to Carlos for inviting me to collaborate to this fantastic library, video library you're making. And thank you to my co-authors. Now, I'm going to talk today about patient-surgeon relationship. And this is okay. Following the general American College of Surgeons, general competency of surgeons includes 6 components. One of these is interpersonal and communication skills. And this is one of the important components. And Satava, who published this paper, says that a surgeon with poor interpersonal and communication skills cannot be qualified as competent. So we all know that poor communication is associated with detrimental outcome. The patients do not feel respected, listened to, or personally engaged by the clinician. That diminishes patient trust, patient dissatisfaction, and finally lead to malpractice litigation. Orthopedic surgeons are really heavily concerned by this problem. And when we hear the compensation companies, insurance company, they say that orthopedic surgeon is first before the cardiac surgery. That is a lot more heavy surgery, but the cause of the litigations are mostly because of default of the relation. Physician did a lot of research on physician-patient relationship, and it is well documented. We know that a good communication has a positive impact on patient satisfaction, adherence to recommended treatment, self-management of chronic disease. And on the other hand, a poor communication has been associated with diminished patient trust, patient dissatisfaction, and malpractice litigation. And there are a lot of publications regarding physicians since more than 20 years. But we are not physicians. Surgeons are different. And particularly, we all know that we are well known not to be interested in the relation. People know that we are more interested and we give priority to technical skills. We don't take a lot of time for emotional preservation, and technical excellence is prioritized at the expense of interpersonal skills. But this is a little bit strange and weird, considering that our responsibility is a lot higher than the one of physicians. We have high-risk procedures, and we have the full responsibility of the outcome, and we can produce irreversible complications. Regarding the literature, we have a little bit more than 20 years. We are a little bit more than 20 years late compared to physicians. To end this introduction, I just want to emphasize the fact that goals of the patient-surgeon relation is not restricted to patient satisfaction. To make a little list, provide clear information, create a favorable emotional climate, understand the emotional aspects, maintain long-term trust, promote shared decision, prevent risk, promote functional recovery, and avoiding conflicts. There has been only one review literature so far. It was published in 2013, but the the paper that were selected were only experienced by recording of conversation during the clinics, and it was completely different than the work we did. Their conclusion is not very surprising. They say that we are quite good providing details about surgical treatments and indications, but we have areas of improvement regarding informed decision-making, expressing empathy and concerns of patients. So we did a new review. We included papers with surgeon-patient relationship and communication in the title. We selected 41 papers, 39 papers and 2 videos, mostly coming from the US, and authors are 66% surgeons. And 40% of these papers are expert opinions. I'm going to go through history of the relation. The Code of Hammurabi, as you know, is like the Italian. If a physician make a large incision with the operating knife and kill him, or open a tumor with the operating knife and cut out the eye, his hand shall be cut off. And this shows that Hammurabi already stated the responsibility of the surgeon and the idea of a compensation. That was 4,000 years ago. In 200 after Christ, Hippocratic oath that we still use in France when a surgeon becomes a doctor, he has to swear the Hippocratic oath. And the concept of this oath is beneficence, non-maleficence, and confidentiality. It was the concept of paternalistic model. The responsibility to act in the best interest of the patient is valued above the rights of his patients. This is a nice illustration of asymmetric power management. Obviously, the surgeon, or supposedly a surgeon, is working very carefully, but takes no consideration of the pain of the patient, and all the people around are just showing no empathy at all. Then it's only in the 18th that the AMA Code prescribed respect of patients' rights and autonomy. And this led progressively to patient-centered relationship, informed consent, and shared decision-making that we use now. Autonomy can conflict with indication of the surgery, and justice is in relation with costs. Emmanuel made a very nice table about 4 different models of relation between the surgeon and the patient. On one side is the paternalistic of Hippocratic. The surgeon decides everything. The informative one is at the other extreme of the table. The surgeon only gives information, and with this information, the patient decides. In the middle, there are 2 columns. One, where the patient knows his goals. He can say what he wants, and then the patient decides the indication. And on the other column, deliberative, then the patient doesn't know exactly his objective and his so the surgeons can help him to understand what he wants. And this is an interesting table that can be really something you can think about when you talk about indication with your patients. Trust is a key of the relation. It's a little bit strange to think that when you're married or when you buy a house or if you do something important in your life, then you have lawyers, you have a notary, advisor, and very often a contract, and a lot of people to sign. It's strange to understand and that having a surgery is also something very important, maybe more important. And there is no, and it's just happening between two individuals, the surgeon and the patient. And usually it's in a very short time. And so what is the solution to this paradox? The solution is trust. The only thing that links the patient to the surgeon is trust. And this relation, that is not a contract, is called a fiduciary relationship. The fiduciary relationship is trust. There are both conscious to put the best, the surgeon put the best interests for his patient, to act in good faith, to provide full and fair disclosure of material facts, not to mislead the patient, to inform him of the existence of any conflict of interest, and to serve patient best interest, even at the expense of their own. So this is a very important concept that builds the relation. Everything I'm going to talk about is to build this trust. How can you build trust? First, by reputation, all the certification, the competence practice, the referring by patients, internet, all the way, the patient can have an idea of your competence, and this is how he starts to have trust in the surgeon. Also by the quality of the communication, empathy, patient-centered priority, quality of communication, openness to patient seeking an opinion, perceived honesty, concern, empathy, compassion, and surgeon's dress and mannerism and appearance of the surgeon office. The power of the patient is very different in the beginning, when he has the whole power to choose a surgeon. Before surgery, the patient is the more powerful. And then suddenly during surgery, it's the opposite. Even under regional anesthesia, the patient cannot move, cannot say anything. If it starts the operation, it will not end before the surgeon finishes the surgery. This is completely different from medical treatments. And it is so important that the surgeon has a high responsibility and the patient has no responsibility at all. And finally, after the operation, there is a place where the surgeon has to continue to give trust to the patient. But sometimes it is more difficult to build this trust, because the surgeon or the patient can have personal family problems, difficult patients, we're going to talk about that, burnout, or the surgeon gave too high expectations. Also, other factors make bond of trust more difficult, like emphasizing technical procedure over interpersonal relation, shortening inpatient stays. We don't stay very long with the patient. Administrative workload, reports of greed, fraud, and abuse within the medical population, feeling that surgeons may operate too often, conflict of interest, lack of transparency. So now we're gonna stop talking about trust and start making an autopsy of a surgeon-patient relationship. First, providing clear information and then responding to patient emotion. Providing clear information is giving all the details, prognosis, all the information the patient needs. And this is something you know very well. But we have to give anticipation of results and functional recovery. We have to give serious or consideration about risks. We have to ensure shared voluntary decision-making and informed consent. Oral communication is very important. Everyone knows that simple wording is mandatory, using patient-friendly terms, no jargon. It should be understandable for a 12 years old patient, and consider language barriers. But I want to give you some consultation tips I remember from all the papers we read. And I think it's important to ask permission to start a conversation. This is important for the patient to know that we ask a question in starting. Ask what the patient thinks about their health. Don't tell him something immediately. Ask questions to find out what the patient already knows. That makes you know him a little bit before you talk. Tell the patient information in an easy way to understand. Gauge the patient's understanding by asking questions after you tell. Listen and reformulate to show that you understood. Use positive statements. Everything's fine is better than you have no complication. Don't check the time on your watch, and finally check to avoid door conversation. There are different types of questions, and it's important to know these differences. Closed questions are, for example, are you okay? And then the patient can answer yes or no, but this is what we call a closed question because he doesn't have any chance to tell something about himself. Semi-closed, how are you? He can say a little bit, well, I'm fine, but he doesn't go very far. And the best way of giving him a chance to express something that's personal is to tell me how you feel. And then he can tell you something a lot more interesting. There is a collaborative communication method you probably heard about, is ask, tell, ask. And asking patient these open-ended questions and trying to have a knowledge before sharing information. So this is a shift from a directive communication, where when you tell the patient what he has to understand, but he will not be very happy, he will be frustrated, he will not be engaged in the process. And it's a lot different from collaborative with this ask, tell model. And I think it's really, it looks a little bit childish, but when you use it, it's very pleasant. I mean, you see how the patient communicates better and how you feel better too. So that was all the sharing information part. But number two is responding to patient's emotion. There is a English expression, being affable, available, and able. Well, this is not enough. What's called patient-centered communication is trying to get close to the patient's feeling. And there are 3 degrees. Empathy is the ability to understand and express the emotions and thoughts of the patient. Compassion is a little bit different because it's when those feelings and thoughts include the desire to help. Well, that's quite simple to understand. And I think we express empathy and compassion most of the time. And there's another stage. Consolation is the relief given to some affliction, pain, displeasure by a gift of attention and presence. This is not very surgical. It's in the case where you cannot help the patient. You don't have any operation or painkiller or whatever, and there's just, it's a little bit depressing, but it helps, and it's important to do this in some cases, and I think it's worth talking about it. So now I'm going to give you some tips to improve patient-centered relationship by body language. Body language is very important too, especially for addressing emotional message. So from the beginning to the end, welcome the patient, walking the patient inside the office, not staying and opening the door behind you. Thank the patient for coming, apologize for being late, that's most of the case. Maintain eye contact to show willingness and sincerity, appear relaxed, appear genuinely interested, use polite touches, gestures, smiles, and nods to show some expression, understanding, and respect. Pick up verbal and non-verbal cues to emphasize patient's statements. Accept patient responses in a non-judgmental manner. Consider cultural history and background. Acknowledge emotion. Do not write and listen at the same time. And of course, express hope. So some basic principle to remember: no prejudice with patients. Particularly, we're not racist or something like this, but work accidents. In France, we are a little bit racist about work accident because or universal health coverage. They are always considered as lazy people that just want to make problems to the surgeons. So this is not good because they have a reaction that's bad reaction, and it's just a fail relation. The first 2 minutes of consultation set the climate, and this is important to know, not to be efficient in the relation straight away. Perceived duration of the consultation is more important with empathy. And it gets too long to give up when the patient talks too much. Don't get nervous or pull it out of the office. Just plan another consultation. So there are tools who can help you to nurture your empathy. And the NURSE acronym is a name or mirror the emotion, understand the emotion, respect the patient, support the patient using powerful words, and explore the emotion further. So it's not what you do, what you say, it's how you say, and do it in a way that patient remember. So this little NURSE acronym tool may be useful. Well, I'm going to shift this. So engaging in informed and collaborative decision-making. Well, we are used to that. I'm not going to talk very much about that, but just to notice that patient capacity to participate in this decision is most strongly influenced by lack of knowledge and option and their preferences and power imbalances. So we have to work on that. Tools for shared decision-making. I just wanted to talk about this best case, worst case framework, but actually it's not something we need very much in hand surgery. We don't have these terrible cases where you have to choose between a terrible operation or just let the patient die. So I think we don't need to talk about this today. Just a word about internet communication. This is a big shift, and it grows a lot. There are pros and cons. Pro, because we can have a relation with patient at long distance with expert specialists. We can address to undeserved populations, elderly and disabled persons, young patients like that, preparation of ambulatory surgery and reducing time spent in clinical visits. But there are cons too, because on internet, you cannot really share, you don't have any emotional connection with the patients. You cannot really have a restitution. The people read some pages on internet. There's a lot of data, but you don't. It doesn't allow to have all the empathy and the compassion and understanding you have with someone in front of you, just because there's eye contact and some body meaning. Increased workload. It can be inappropriately used. And there are some medical issues that are difficult to manage for the moment. So electronic tools are not available to everyone, and this is certainly a barrier for a lot of surgeons too. Well, there are also some special situations. Informed consent is a special situation. Not a lot to say about that, but it's not only oral, it's written and signed. So this makes a difference. And it was well demonstrated that failure to obtain adequately informed consent leads to failure to communicate this effectively to the patient and undermines trust and leads to litigation. Another special situation is difficult patient. Well, maybe you never have difficult patients, but sometimes I have some. And I know most of us see difficult patients. Who are these difficult patients? They are difficult because they're aggressive, challenging our indication, psychologically fragile, not engaged, certainly not collaborating. They are very demanding, sometimes illiterate or have language barrier and bargaining fees. Well, they are aggressive or difficult for some reason. And this irritates you. It irritates all the surgeons. But we also have some difficulty sometimes because we perceive this like aggressivity. We perceive culpability sometimes. And we project this aggressivity on our target points in our psychology. And sometimes we are close to burnout. So more than difficult patients, I think the problem is difficult relation. I'm sorry for that because I had a little animation here, but difficult patient and difficult surgeon makes a terrible clash. So the situation here must be managed by the surgeon who understand that he can calm down and use all the tricks we talked about so far and go back to the patients and try to make this difficult situation, not in a difficult relation, but in a normal relation back again. Okay, that's it. And then empathy and communication skill may return to a normal relationship. So another situation is to deliver bad news. There is a little instrument spikes. That's interesting. And you have to understand that sometimes you have to allow for silence and tears and proceed at the patient's pace, have the patient describe his or her understanding bad news, repeat the information at subsequent visits and allow time to answer questions, write things to provide written information. This is difficult for us. And I must say that maybe we need help, and because it needs a lot of time. Another difficult situation is disclosure of errors. And these are the components of disclosure that matters to patient. The recommendation is to clearly state the facts. And it's important to say without passion. State everything that's positive, disclosure of harmful errors, explanation about the error, how the error's effects will be minimized. That's, of course, very important. And steps the physician will take to prevent recurrences. If it's a second advice, he has been, there's an error by another surgeon, don't charge, don't deny. Don't say, oh, who did that to you? That's certainly very, very bad. And recommended answers you can give it. It was difficult, and the first surgeon did the best he could. And I already saw this happening. But remember that in this graph, disclosure is difficult. Even in this paper, partial disclosure was 56%, and full disclosure only 42%. So this is a very difficult topic, and we are not, it's difficult to be perfect in this situation. But something that must be emphasized is that when you have a post-surgical complication, you're going to suffer. And this failure of the patient to respond is something very, very painful for the surgeon. So avoid inappropriate behavior. Don't say it's in your head and you need a psychiatrist and I cannot do anything for you. Don't close the communication. And remember that feeling attacked is painful, but if you have the courage if your loyalty may make you even more grateful. Now I want to give you some information about the measures of the relation, because as Lord Kelvin said, if you cannot measure something, you cannot improve it. So PREMS, patient-reported experience measures, validated. There are some PREMS to measure the patient-surgeon relationship. I'm going to go through these measures, just that you can use them and be aware. So the Wake Forest Physician Trust Scale is, of course, a scale that measures trust. 10 questions, and it's, of course, the patient who fills it up. These are patient-related questionnaires. Another one is the care measure, and this is only measuring empathy. It was, these are the questions, also 10 questions, and it's also a patient-reported measure. The SURE tool is interesting because it allows to give a score to decisional conflict for after you make an indication and you want to be sure that the patient understood all the pros and cons and made the right decision and will not regret it afterwards. So this is a 16-question questionnaire that should be used. This is another questionnaire that measures all the experience of surgeons, nurses, administration during surgery for cancer patients. This is not exactly what we use every day. And I want to talk to you about this questionnaire that we developed in 2014, I think. I don't know why I have the 2017. And it's 11 questions about patient-surgeon relationship. And this is the only questionnaire that measures the patient-surgeon relationship. 11 questions. It's easy to fill out. And I'm going to show you this, this graph where you see all these questionnaires. So care, empathy. Q-Passerelle is 2 for empathy, compassion, 2 questions, 2 on clear wording understanding, 1 on administrative assistance, 2 on availability, 2 on consistent team communication, and 2 on recovery planning. So this questionnaire is specifically dedicated to patient-surgeon relationship in the context of return to work. So before the end of this lecture, I'm going to go through 5 evidence-based benefits of a good patient-surgeon relationship. One is that patient-centered dialogue quality may be more important than making visits longer. And that's a very good news. If you stay long with the patient and you don't transmit empathy, compassion, patient-centered relation, then you lose your time. Highly patient-centered communication can protect against the loss of trust that can accompany surgical complications. This is very important too. If you have a good relation, you have a high trust from your patient, it will help you and your patient to go through difficult complications. Behaviors, that's an important thing too. Surgeon communication behavior that lead patient to not recommend the surgeon to family members or friends. It's very simple. Behaviors omitted most commonly in encounters where patient recommends surgeon include failure to show interest in the patients, 52%, explain their medical condition, 52%, invite questions and answer questions. So it's clearly related to the quality of understanding of the patient's needs and the way you ask questions. This paper shows that the findings of the study support the role of a positive patient-surgeon relationship in achieving long-term follow-up in post-bariatric surgical patients. And these patients are particularly difficult. Finally, using the Q-Passerelle I developed just before, the question was impact of patient-surgeon relationship on patient return to work. And the results were striking because the blue column is the number of patients who returned to work within 6 months after enrollment. These patients were very severe hand trauma. And the white column are patients who did not return to work 6 months after enrollment. And you see that on the left, it's a low relationship, low pastoral score. 19% of the patients return to work only. But in the high, when the relation was very good on the right, 75% returned to work within the 6 months after enrollment. So you see that even in these, maybe because they were with a very severe trauma, the relation was extremely important and saved a lot of time out of work. In conclusion, when I talk with colleagues about this patient relation, most of them say, oh, I think you're right. It's very important. And I'm quite good at that. It's incredible. I hear this all the time. But when you look at this clearly, to have a good relation needs interpersonal skill that we don't have. Needs more learning. We never learn. We never learned this when we were residents. We don't talk about this in meetings. It's never measured. And it's not compared with peers. So it's a little bit paradoxical. Training surgeons to communicate is for sure something we have to increase. There are a lot of techniques to help to communicate with patients. And for sure, the relation is important for the patients. It's also important for the surgeons. And it's also important for stakeholders. Because when you remember you have a good relation and the patient comes back to work earlier, it saves a lot of money. And with this improvement, with this new tool, if I can say, well, we never reported any side effect. Well, the conclusion of the conclusion is stay patient-centered. And as you see, the best situation is when the patient is not here. I was starting a replantation that day, and I was perfectly calm and no problem with the patient. Thank you very much.